Oh, amazing.
Do you know, I was thinking, you guys comfortable? Do we ask questions, or do you think you're happy for me and La just to have a chat and then ask questions at the end? How do you guys feel?
If they're easy questions,
throw us in.
It's actually not too bad, I think. Well, maybe
I've got a thought for that, actually. As I was editing the last video, and I thought, we want to keep it safe place and all that. If people write this is at the end when people have any questions. If they write it down, then I can ask you the questions that they've written down, so no one's face is on, and no one's voice is on, but good questions can still be posted. Yeah,
good question. Yep, good point. Now I actually want to show you guys what I actually found in Miller's, which is going to be wrong. So, that's what I've been working on all morning, just to make sure that that the burden of proof is there when I go and show you this slide in Miller's. Kind of nice. Crazy. Maybe I should put them side by side, actually. Yeah, okay, no, I'll do it this way. And then at the end, so I'll actually show it to you, La, first, and then I'm sure you can sort of spot it, and then we'll have a chat about it side to side. Maybe. Okay, good. Okay,
do you want to show me now or during?
I'll do it. It's pretty obvious. As in, I'll just get you to read it off the slide when I sort of present it, and then we can have a discussion about it.
Yeah.
I think that's what we'll do. Yep. Okay.
So should we get started with the thing?
Yes, let's go.
Yeah, beautiful. Hi everyone. Actually, I'll just make sure that my it's flipped onto me so far. So hi everyone, and welcome to Anaesthesia Coffee Break and Adrenaline Memories. We're doing a little shoot this morning and discussion about local anesthetics. And so Stan, how's it going?
Good. It's been absolutely super busy this week. We've been celebrating the trainees who passed the last exam, and it's been lots of fun. And I think that's one of the best moments when we can sort of share those experiences with our trainees and with you guys who are going to be there in 6 to 12 months, I'm sure. Oh, sorry, less than that actually, but yes.
You did such a great job. I mean, for our particular training team, Northwestern training team, pretty much everyone has got through. It's just a ridiculous amount of work and achievement, kind of coaching and everyone studying and working hard and building that community. So yeah, really well done, because that's an amazing achievement.
As I said in the group, it's a team effort. And I think one of the key things is that, we've got a lot of good structures and supports in place in our program at Northwest. And you know what? I just want to share it with all you guys out there. So that's the main key goal, is to have every one of you outside of our Northwest training scheme also be successful and pass the exam and really enjoy the experience. I think that's the main key goal here.
Beautiful. And I've got an ulterior motive as well, because the West Australian guys are really kind. There's this pot plant behind me that you can see on the YouTube video, but that was a gift from them. And yep, thanks West Australian guys. Shout out to you for having a really great exam session and everyone getting through. And yeah, well done.
I think we've got a soft spot for the WA trainees.
Yeah, that's right. Now, should we crack on to get straight onto this question?
Yes, let's do it.
Fantastic. Okay, so this was a 2016 question from the first sitting, question number 6, and it says, discuss the factors influencing the speed of onset of blockade of a major peripheral nerve with local anesthetic. What do you think of that?
So look, one of the key things I want to point out with this question is that we're just going to focus on speed of onset, but there are certainly other concepts surrounding that we're also going to touch on and discuss as well. The other thing here is that it's talking about a major peripheral nerve. Now, I'm just going to expand on that idea because there is certainly a differentiation in terms of onset and also the type of nerve involved as well. So in other words, we are going to answer the question, but we're also going to go a little bit beyond that with some concepts related to answering this question. And look, I think for this question here, you can really structure it with Fick's law of diffusion. So this will describe the physical chemical properties of the local anesthetics. And we know that Fick's law of diffusion is the rate of diffusion is proportional to your concentration gradient, your solubility divided by the square root of your molecular weight, and also multiplied by the surface area divided by thickness. I think you'll see that formula replicated multiple times in different concepts, so kidneys, other drugs as well.
Excellent. And so I like the fact that obviously you're breaking it down, you've got your categories all sorted, but you also, nothing in the stem is ever accidental. I feel like it would be very easy to forget the fact that they've said major peripheral nerve, but that's in the stem, and nothing the examiner's put in there is by accident, and you have to address that. So physical chemical properties and characteristics of nerves are, I guess, the two ways you're approaching this, and you've done Fick's law. So yeah, could you describe each component?
Look, I think before we go into that, I think it is important to have a brief overview of how local anesthetics work. So if I was to just describe it, what you would have is you'd have the local anesthetic would be deposited near the nerve. And here, after it's deposited, it can be removed. So it gets removed by tissue binding. It also gets removed by the circulation, and also with local metabolism when we're talking about ester local anesthetics. The key point here is that it's the free drug that penetrates the nerve, into the nerve. And when we're talking about into the nerve, there's a couple of layers that you want to know about. So it's the epineurium, the perineurium, and the endoneurium. And it's the perineurium that's going to be the biggest barrier to diffusion. Now, the speed and extent at which it diffuses across is dependent on two key things, the pKa and its lipid solubility. Now, the transmission of signals, they're primarily via depolarization via voltage-gated sodium channels. I'm just going to give a really brief overview here. So these sodium channels, they can exist in three states, the resting, active, and inactive state. And the binding is in the pore of the channel. Now, to access the pore of the channel, the sodium channels either need to be in the active or inactive state. So they can't be in the resting state, which is the closed state, okay? Now, the way that it sort of interacts with the channel is that one, it can stabilize the channel into the inactive state. And you'll see this theory called the modulation receptor theory. The other way that it can block is that it directly blocks the channel, and that's called the guarded receptor theory. So you'll see these two theories, and that's what they mean. Now, I think that the key points here are going to be solubility and pKa. And what are your thoughts about that, La?
Yeah, I was just thinking, I mean, so solubility and pKa, they really relate obviously to the Fick's law of diffusion. You know, I just find that all the different categories of drugs, they seem to invoke these principles of pKa and solubility, but solubility is directly mentioned in the Fick's law of diffusion, whereas pKa is not. It's almost like a surrogate which increases solubility or transfer. Are they both equally important, or is one more important than the other?
Great question. So look, for local anesthetics here, it's the pKa that's going to be the most important, because that determines the degree of ionization and unionization, and it's the unionization fraction that actually diffuses across.
Yeah, okay. And so why not solubility? Because I guess it's lipid solubility that they're specifically talking about when we talk about solubility of local anesthetics, but why not lipid solubility as described by Fick's law?
This is a really good question. And this is something that I think trips up a lot of people, okay? Because when we think about lipid solubility, our direct association is that the more lipid soluble a drug is, the quicker it works. I think that's a very general theme that we can think about in terms of our IV induction agents. Wouldn't you agree, La?
Yeah. As in, yeah, go on.
Yeah. And so the key thing here to understand about local anesthetics is that there is an interplay between lipid solubility, protein binding, and potency. So I'll repeat that concept again. With lipid solubility with local anesthetics, there is an interplay between the lipid solubility and protein binding and the lipid solubility and its potency. In other words, when you increase the lipid solubility of local anesthetics, you are also going to be increasing protein binding. And remember what I said at the start, when you give the local anesthetic near a nerve, what takes it away is three things. It's protein binding, it's going to be taken away by the circulation or the vascular supply, and it's going to be taken away by or removed by metabolism, specifically for ester local anesthetics. Now,
so practically speaking, none of these things happen in isolation, is what you're saying. That's why you can't just increase one without having effects on the other in a practical sense. And then this kind of also relates then back to, opioids, I imagine. Fentanyl, highly lipid soluble, very potent, and you just use less of the drug when you're giving it, irrespective of the pKa.
And that one there is actually related to the pKa of fentanyl versus L-fentanyl. So that's a really good point as well. That's a really good example as well. Now, the other thing that I also want to mention is that when you increase lipid solubility, you also increase the potency of the local anesthetic. So when you increase the potency of local anesthetic, it actually means you're going to be using less of the local anesthetic. And, a classic example is bupivacaine versus lignocaine. Bupivacaine is more lipid soluble, it's got more protein binding, and it's more potent. And therefore, what that means is that it's got a slower onset because you're going to use less of the drug. And remember, it's that mass effect. Because lignocaine is less potent, you're going to use more of the drug, which means that there is more of the drug available to diffuse across. And that refers back to that concentration gradient as part of Fick's law of diffusion. Now, I think the other thing that trainees will often ask, they go, well, how about if it's the other way? In other words, how about if there is a local anesthetic that is less lipid soluble, which means that it's got less protein binding? Well, this is where there needs to be a balance. So you have to be moderately lipid soluble, something like lignocaine, because local anesthetics with very low lipid solubility, and the one that comes to mind is going to be procaine, which is one of the ester local anesthetics. It's got a slower onset. So even though it's got very, very low protein binding, it's got a very, very slow onset. And the other thing that you can also say that it's also because it's got a much higher pKa as well. But, all those things come into play.
And so, none of this stuff is linear. It's not like you've got this, isolated thing called solubility. And the more it is, the less, the slow onset is, and the less lipid soluble and the faster onset is. It just doesn't play out like that. And maybe I like the fact that you're giving these examples, and in a context, you're giving examples of procaine and bupivacaine, because then in the exam you can write these down as your examples and discuss them rather than discussing just the factors themselves. So you mentioned then pKa. So why is pKa important? And this scares me a little bit because in my head there's all these negative log fractions of drugs in my head, and how do you visualize that and explain that?
Yeah, so really good question. Now, I think some of the nomenclature out there can be a bit confusing. When we talk about the pKa, it talks about the dissociation constant, where it's 50% ionized and 50% unionized. Specifically, when we're talking about pKa, the A actually stands for acid. Now, local anesthetics are bases, and that's why sometimes you'll see the terms pKb used. But I think that for most intensive purposes, it's accepted that we're going to use the term pKa. But just know that there's a difference between acid and bases, and sometimes you'll see those differences there. Okay, really, really important to know that, because when we think about the Henderson-Hasselbalch equation, so this is where pH equals the pKa plus the log of bicarb, concentration of bicarb, divided by the concentration of CO2, that is for an acid. And the bicarb represents the ionized fraction, and the CO2 represents the unionized fraction. When we think about it in terms of a base, you have to flip that around, okay? So for a base, the pH equals the pKa, or sometimes you see it as pKb, plus the log of the unionized drug over the ionized drug. Now, I say that, and I don't think you need to memorize it, but I do think you just need to be aware of it so that when you come across it, you can understand the differences and you can understand why it's explained a little bit different, okay? Because remember that the Henderson-Hasselbalch equation is talking about an acid. And sometimes when we apply that to a lot of our anesthetic drugs, most of our anesthetic drugs are actually bases. All right. Now, I got asked this by a patron in terms of how do we calculate the ionized and unionized fraction. Look, I think that it would be unreasonable for you to prove that in the exam because it requires you to understand about taking anti-logs for both equations. And whilst, you know, if you practice it, yes, you can do it easily on the day. It is, I think, overly complex, and I don't think it's necessary. And the other thing that you need to also do is that you need to change the ratio or the fraction to a percentage. And so there becomes like this, I think that there is that bit of confusion in terms of how to do that. But what I'll sort of show you is just a formula that you can use that can actually calculate the unionized fraction. So what I'll do is I will bring up my little keynote here, and I'll put a new slide in here, and I'll paste it.
I understand. You're saying, really, you don't need to know how to calculate these things. It's going to anti-logs, and I think we're all a bit relieved that you're not going to be tested on some intense maths as much as we all love maths.
That's right.
But you're saying that if you were to remember anything, if you had a bit of extra brain space, this is the formula for ionized fraction for bases, and this is the formula for unionized fraction for bases, and that's the thing to remember, if anything. Is that right?
Yeah, and look, I'll show you how to calculate it. So I'm just going to go into my Zoom here, and what I'll do is, live. For those listening, obviously on the podcast, you won't be able to see this, but live, if you could read it.
Yeah, absolutely. I'll put this in the story notes in the podcast, so that's all good. But 10 to the power pH take away pKa divided by, and is in brackets, 1 plus 10 to the power pH minus pKa is the unionized fraction for bases. Is that what that reads?
Yeah, and let's do some examples here. Okay, so let's say the pKa and pH are equal to one another. So that would mean 10 to the power of 0. Agree? Yep. And what's 10 to the power of 0? 10 to the power of 0 is going to be 1. Yep. Okay. So when pH equals pKa, all right, that would mean that you get 1 divided by 1 plus 1, which equals?
That's just 50%.
50%. Exactly. And that's exactly right. So let's use an example now of lignocaine. So we know, and we know you'll see different numbers for the pKa of lignocaine. You see 7.8, 7.9. Let's just use 7.9 just because it's easy. All right. So now we've got pH is 7.4 and your pKa of lignocaine is 7.9. All right. And therefore, if we do that, that is 10 to the power of minus 0.5. Would you agree?
Yeah, absolutely.
And can you quickly do that on your calculator? What does that equal to?
No, you assume that I've got a calculator that's going to...
I was assuming that you've got a calculator brain, Lahiru.
Yeah, that's right. Why don't you just do it and you just let us know?
So I think it's going to be about 0.3 from memory. but double check that. And then it's going to be 0.3 divided by 1 plus 1, 0.3. And what does that equal? 0.3 divided by 1 over 1 plus 3 is?
0.3 divided by 1.3. That's 0.23.
Yeah, it's about 0.23 or 25%.
Yeah.
Yep. I think it's a little bit more than 0.3. So it's going to be around 25%. And guess what? The unionized fraction of lignocaine is?
Yeah, so unionized will be 25%.
Around 25%. And those are the numbers that you see. Now, you might see another example, which is, I think, tetracaine. Tetracaine has a very high pKa. And let's use an example now where the pKa of the drug is 8.4. Okay, so pH equals 7.4. Your pK of a drug equals 8.4. Now, 10 to the power of -1 is going to be 0.1. Okay, and then 0.1 divided by 1.1, that will give you approximately 9%.
Yeah, beautiful.
Yep, or not 9 to 10%.
Now, just for everyone watching, this is absolute. This is more for understanding. Yeah, you're given the formula. This for understanding. You know, there's no way you're expected to. I mean, do you think that they want you to write this formula down in these?
No.
Okay.
But I think it helps you understand in terms of, you know, where these degrees of ionization and unionization comes from. Okay. Look, I think if you know this, look, it's a bit hard, but obviously if you can understand this formula, the 10 to the power of pH minus pKa divided by 1 plus 10 to the power of pH minus pKa will give you the unionized fraction. You can calculate any ionized fraction for any basic drugs.
Any basic drugs. So this is also for your opioids, is also for your, you know, really any of the base drugs for anesthetics, you can do that.
Yes, correct.
Where the other ones are relevant, really, it's opioids, not really muscle relaxants.
Now the thing is, if you want to do it for acids, it does the unionized fraction for acids.
Ionized fraction.
Ionized fraction. So if you want the unionized fraction, you have to actually change the formula around, where you got to go to 10 to the power of pKa minus pH.
Beautiful. And that's actually easy. You just take away the percentage and you get the ionized fraction.
But you can see why this is so confusing. And I don't want to confuse everyone out there, but I think that because I was asked this question, I think it's good just to sort of explain it. And so that you sort of know and appreciate, I think, the way that it sort of worked out, and the way that, you know, your application of the Henderson-Hasselbalch equation occurs for these drugs.
That's really elegant. That's really good.
Yep.
Should we move on to molecular weight?
Yeah, look, molecular weight is interesting. So it doesn't play a big role. I think when you look at the amide local anesthetics, you can sort of say that that the faster working local anesthetic agents tend to have lower molecular weights. So things like prilocaine, lignocaine. Lignocaine's got a molecular weight of 234 per mole, compared to bupivacaine, which is 288 grams per mole. But that also fits in with the idea of lipid solubility, because the reason why bupivacaine has a higher molecular weight is that it's got more carbons in it. Now, I guess where this sort of doesn't sort of correlate is when you look at the esters, because the esters tend to have a much higher molecular weight, and some of them, like cocaine and tetracaine, actually work just as quick, despite them having high molecular weight. So that it's something a little bit more than just molecular weight. Okay, but I guess when you're sort of comparing like to like for local anesthetics, so when you're comparing the amide groups, the smaller molecular weights will tend to have a faster onset. And maybe that's the way that you could add that concept in for this answer here.
Yeah, okay. Oh, is this a situation like muscle relaxants where the molecular weights aren't overly, like, you know, obviously they're different, but they're not magnitudes of order different, so they don't make much of a difference? Is that?
I think so.
Okay.
Yeah.
Okay, good. So that's molecular weight. How about surface area? How would you go about explaining that?
So what I would do with surface area is that I would bring in the concept that you need to block at least 3 nodes of the Ranvier. So the Ranvier nodes, they talk about there's a minimum amount of these little gaps that you need to block, and 3 is the optimum. And the way that you get that minimum of 3 is through local anesthetic spread. The way to get local anesthetic spread is to use volume. And that's where I would introduce the idea that if you use higher volumes, you would tend to get a lot more spread, a lot more coverage, a lot more surface area covered. Okay.
Yeah,
and I think that makes sense. I mean, for us, when I think about the blocks that I do, I would tend, if I wanted to have a faster onset, I would use higher concentration, and I would probably use higher volumes as well.
It makes a real appreciable difference. I think of the fast-acting blocks that I'll do regularly are the eye blocks. And if I use 2 mils in a subtenons, it takes ages to work. But as soon as I put, I generally put 3 mils. But if I do use 4 mils because I really just need to get that patient in, then it is such a rapid onset block. But we were just at this conference in Wellington, and they were trying to. Were you in that? Yeah, you were with me in the audience there, where they're talking about the phrenic nerve effects of interscaling blocks, and they're doing studies on 5 mils versus 15 to 20 mils. And it was kind of the captain obvious of statements where 5 mils of anesthetic will, it's far less likely to paralyze the phrenic nerve, but you just have less chance of, a successful block.
Yeah.
And I thought, well, that's kind of obvious. That's good.
It makes sense. And I think that when you're first starting off, you'll find that higher volumes are often that give you that margin of safety. But as you get technically a lot better with, ultrasound and your needle technique, and you're comfortable with, getting closer to the nerves, that's when I think you can lower your volumes down.
Yeah, absolutely.
Hey, I was going to ask you before you go on, do you use sodium bicarb for any of your local anesthetic solutions to quicken onset?
Only for obstetrics, for the epidural top-ups. And that's because it's such a system in place, but I've never added it. Actually, no, maybe I've added it once to a case. But no, it's not something I regularly do. But I'd totally be I wouldn't be against adding sodium bicarb.
And just for the audience, Lara and I work at the same institution. What's the amount that you use for the local anesthetic solution for the epidurals?
Yes, I mean, we usually drop like 18 mils of 2% lignocaine, add in 100 mics of adrenaline, so that's roughly 5 mics per mil, or 1 in 200,000, and then 2 mils of the sodium bicarb, and then another 2 mils is the fentanyl that might be added onto that as well. Now that bicarb percent, that's a 1% solution, or some.
Sodium bicarb comes in 8.4%.
Beautiful, 8.4% solution. So 2 mils of 8.4% is what we add in.
Yeah, and so I think the audience might ask you, why do you add adrenaline in?
Yeah, I mean, simply for a longer lasting block, the epidural space is so vascular that you can get just rapid dispersion of your local anesthetic. Adrenaline just gives you that margin of safety. And again, you're in this, cesarean section. You don't know how it's going to go. You just want to make sure you've got a bit of margin of safety. And it's such a safe drug to give, as long as you're not, even if you're intravascular, you'll figure that out with the test doses that you give. So you'll completely know of the risks, and 5 mics per mil of adrenaline is so safe.
Yeah, I agree. And, I think one of the things that I often get asked is, does adrenaline quicken the onset of local anesthetics? And the logic that they'll often say is that, well, Stan, you've said that, when you give the local anesthetic near the nerve, one of the things that occurs is that, or that takes the free drug away, is that it gets tissue bounded, it gets removed from the vascular circulation, and that it gets metabolized. And they go, well, adrenaline theoretically vasoconstricts, decreases your vascular supply, and theoretically should increase the concentration of the drug at the nerve. So why doesn't it increase the onset? And I think the key thing is that it doesn't statistically increase the onset. So I think the studies have shown, when they looked at using adrenaline, from what I've seen, it's a little bit quicker, but not statistically significant. Okay. And I think that's the key thing. And I think there are a couple of reasons for that. So I think the primary reason is that when you look at the onset of effect of lignocaine, it's a couple of minutes. They talk about adrenaline having the maximal vasoconstrictor effect at about 4 or 5 minutes. Okay. So I think by that time, local anesthetic has already worked already. And therefore, it's more important in terms of duration than it is for onset. The second thing is that adrenaline actually comes in acidic solution. So when you add an acidic solution to a basic solution, you're going to decrease the pH. And we know what happens when you decrease the pH with local anesthetics. You're going to increase the ionized fraction. And if you increase the ionized fraction, then that decreases the amount of diffusible drug that goes through. And I think the classic example of creating acidic environments would also be in like infected tissues they talk about. Yeah.
And so, I mean, knowing that, are you surprised that more people don't use sodium bicarb for every block? Or, you know, even like, let's say you are trying to inject around an abscess just for whatever, so the surgery or post-op pain relief, why not give sodium bicarb added to all of these solutions?
I think that is an excellent idea. And, you know, I think that if you had a case where you felt it was important for the patient to have a regional technique, and that the patient had an infected tissue. So a couple of things is that yes, you could use sodium bicarb around the tissue, or you could actually go a lot more proximal. So do a more proximal block for that patient to block that limb. But yeah, look, I think for most of my elective cases that I do, and I do a lot of orthopedics where I'll use 1% Narrapin, it's not time critical for me to get that block in within, 5 minutes. Like, you know, I can have the onset come on at about sort of 10 to 15 minutes just because of the workflow that I do, where I do it in the anesthetic bay, get the patient across, get the patient in position. By the time the surgeon preps and drapes, it's about sort of 15 minutes is when the onset occurs. But certainly, I think when you think about it in terms of using it as an epidural for a cesarean, especially emergency cesarean, you do want to have that quicker onset, which is why we used sodium bicarb at our institution. But in saying that, I've been to other institutions which don't use sodium bicarb, and I'm sure you've been to the same as well.
Still works fine.
Yeah, I think, appreciably, probably just about in a couple of minutes, I would think, 1 or 2 minutes.
Yeah, okay. What is your block formula, by the way, for an interscaling?
So my interscaling blocks, I would use probably around 8 mils of 1% Narrapin, so high concentration. And I would also add some additives as well. So I would add some dexamethasone and some clonidine as well. Okay. Yeah. And the dexamethasone and clonidine is not for onset, it's for duration. And I think that's another topic for another day when we think about what affects the duration of local anesthetics.
Yeah, sounds good.
Yeah.
So just to quickly summarize there, surface area, you need a lot of volume. You need to cover 3 nodes of Ranvier. I love that. That's a fact there. That's really interesting. And yeah, so we talked about surface area. Now, what affects thickness?
Well, thickness, the way that I think about thickness, when we think about local anesthetic, is going to be distance to the nerve. So in other words, the closer you are to the nerve, the faster the onset. And I think that makes sense. The further away you are, the longer it's going to take. And certainly, with the advent of ultrasound and being able to visualize the nerves, you can find that you can actually get very, very rapid onset, relatively rapid onset with most local anesthetics.
I remember seeing this study about, in intraneural blocks, obviously not for the big trunks and stuff, but for things like supraclaviculars. And, I think there's a guy who did a whole series of these, which was just small volumes, 1 or 2 mils in an intraneural space, and just getting super fast onset. And, because he's using a blunt needle, it wasn't a cutting needle. Again, probably not the technique you want to be doing when you're first starting out. But yeah, that kind of very much proving the point of speed of onset.
Yeah, I haven't dared do it yet. I've read about it, but it's not something that I'm super comfortable yet. And also because I think that the techniques that we have of putting local anesthetic around the nerve works just as well. But yeah, I guess it's comforting to know that if you inadvertently do a intraneural injection, as long as you realize it, if you just inject 1 or 2 mils and you notice that, there's a lot of pressure here, it's still safe. I think where you can cause significant morbidity is when you don't realize it and inject the whole, your whole 8-10 mils into that neurovascular, into that neural bundle.
It really is like you're either damaging nerves with cutting through them, damaging, or it's increased pressure causing ischemia. So you really got to watch out. And maybe just a disclaimer, if you're looking at interscalene, it's big trunks. So it's got a very high axon to stromal ratio. They're more at danger. But if you're looking at peripheral nerves, they've got a very low axon to stromal ratio. There's lots of space around these little nerve bundles, which do have space to expand and, probably a bit safer. But again, probably a talk for another. With the thickness, often use hyalase for eye blocks, and that's one of the game changers. Really, like it really does appreciably speed my onset. Hyalase is almost like decreasing the thickness because it's an enzyme that's breaking down tissue. Would you add that, or would you talk about that in this situation?
I think that's a great one to add, especially for eye blocks. There's certainly really good evidence for the use of hyalase in eye blocks, and you do a lot of eye blocks, don't you, La?
Yeah, just put 30 units per mil in.
And so you've seen the difference between using hyalase and no hyalase.
Oh yeah,
right.
Yeah. I'm trying to simplify my technique to the most easy thing to draw up, just for safety and efficiency. And really, I can't get past. I've gone down to just using 2% lignocaine, but without hyalase, it is incredibly slow. But with hyalase, it's super fast.
Yeah, and I think for that kind of list where it's quick turnover, it is important to get sort of quick onset, isn't it?
Yeah, absolutely. So finally, characteristics of nerves. This is going back to really the second big category in the question of a major peripheral nerve. What are the factors affecting that speed of onset? So yeah, tell me about that.
So look, this one here, you probably don't need to add this in this answer here because the answers, the question specifically asked about a major peripheral nerve. So a major peripheral nerve is going to be one of your A delta nerves. Okay. And I think that when we think about it in terms of nerve distribution, I'm going to show you this table, and it's from Miller's, and I want you just to describe it for the audience, and then I think we can sort of go through it from here. Okay, so can you see that, La?
Yes, I can.
So this is table 29.3 from Miller's. This is from Miller's. All right.
Yep.
Like the latest version of Miller's. So what do you think? So the fiber class?
Yeah. And so here we've got, fiber class A, you got all the subclasses, they're all myelinated, which is important. So you're going to have kind of larger diameter, fast conduction nerves, and it really is like proprioception, motor function.
Yeah.
But here they've got pain, cold, and temperature. That's right. So A delta can be pain, cold, and temperature, and susceptibility to anesthetic block. That's interesting, but it looks here like it's saying.
Yeah, good. And I'm glad you put out that first point that A delta is for pain, because what have they got here on this table here?
Yeah, it says muscle tone for A delta, and I think they meant to.
So that's the first mistake. First mistake is that you spotted it right away, La, and I haven't even shown La this table. So the one that's going to be the subclass for your muscle spindles is actually gamma. Okay. So A delta should be the one below, and that should be for your afferent sensory nerves, pain, cold, temperature, and touch.
So since you've identified a couple of mistakes in Miller, do you get editors' rights now? Like, is that?
No, definitely not.
Anyway.
But what do you think about the susceptibility to local anesthetic block? What have they said there?
That makes sense. The lower the diameter, the less myelinated, the more susceptible, which then really, as you go through, the fiber class B and C, it's showing less susceptibility, which doesn't seem quite right. Your C fibers are tiny fibers, unmyelinated.
Yeah,
they're the most susceptible.
Yes, I 100% agree with that idea, because I'll show you the next slide. So the next slide is table 20.2 from Hemmings and Egan.
Completely contradicts with
yes,
fiber B and C. And
what have you got there?
Yeah, exactly.
So this is for the audience on the podcast. We're looking at table 20.2 from Hemmings and Egan now.
Beautiful. And so, yeah, fiber B and C, they've pretty much done what we would think is the correct notation for sensitivity to block. So they've got, 4 pluses for B fibers and C fibers, B fibers being the autonomic type fibers, C fibers being pain, temperature, touch fibers. And again, they're very susceptible to block. So this table looks far more accurate. Even going into A delta fibers, which have 3 pluses for sensitivity to block, because they're a bit larger than the C fibers. So yeah, this seems pretty accurate.
And I think, and I think in terms of representing this as an answer, I think this would be the most accepted, because this is what we see clinically. I think that, if you think about it in terms of sensitivity, we would say that B fibers, from going from most sensitive to least sensitive, we'll start with B fibers, C fibers, A delta, A gamma, A beta, and A alpha. Yeah. And we see that, don't we, La, when we do our epidurals, because often what gets knocked off first, it's actually the sympathetics.
Yes. And the fact that they're pain, or it's like, say they're having contractions, those will go away immediately, but they'll still be able to move their legs.
Yes. And that's the A alpha, correct.
Yeah. And it's interesting, like this was, I used to read a lot of IJO, so International Journal of Obstetric Anaesthesia, talking about, what is the best marker of effective block for a cesarean section. And most of the time we're using bilateral absence of cold to T4. That's like kind of the standard. It's easy to measure. You get a bit of ice and you do that. But the studies have shown, I hope I get this right, but block of light touch to T5 bilaterally is the best indicator that you're not going to have any problems with, or, your spinal is going to last for the cesarean. And the next most effective measure is motor block presence. So inability to move the legs. So cold and pain are the least effective measures. But it's just interesting because we use cold as our standard one. And that makes sense. I mean, it seems a bit odd because you're thinking, oh, well, pain's my endpoint, so surely that should be the thing I should be testing for. But the way I see it is, if you're blocking motor and light touch, the really difficult to block fibers, then the chance of having a problem with your block is going to be far less likely.
Well, that's a really good point. And when I was a registrar, and credit to Ian Letson, if he's still out there, I think he's still at the Mercy. So Ian Letson was my senior registrar, who's now a consultant. And that's exactly what he told me. And I actually don't use cold to test for my blocks for cesareans. I actually get the patient to actually touch themselves and to actually pinch themselves. And I think it just reinforces the idea that, the idea of pain is a very, personable, subjective experience. That's, there's so many layers to it, because people can perceive a lot of different sensations as pain or discomfort. And so it's important for myself, when I interact with my patients, to let them know what is normal and what's not normal. And I think that cold thing is quite arbitrary. So I actually get them just to pinch themselves. And I think it adds a little bit more realistic idea in terms of what they can expect and what they shouldn't expect. Because then after that, I start pinching them up on their shoulders and I say, this is not what we expect. And then they pinch themselves down below. So
that's really interesting. So yeah. I actually really like that, to prove to a patient who's nervous that they're not going to feel, the pain of a cesarean section. Just get them to cause themselves a bit of pain in a safe way. Yep. Do you then check? Do they check light touch as well? Like they kind of prove to themselves that they can't even feel light touch? Or?
Yeah. So when they do it, it's funny when you see them try to pinch themselves. They actually just touch themselves quite lightly, and you're like, no, I want you to like really, really grab a piece of skin and really pinch it as hard as you can. So they actually just do a bit of light touch at the start, and after that they start pinching themselves. And then that's patient initiated block level. Yeah, patient initiated assessment of block level. That's what I do. Now I just wanted to show this paragraph because this is in Miller's. And again, I just want you to be aware of it because this is contrary to what Lara and I just talked about. And I think what other textbooks also say as well. So Lara, do you want to read out the highlighted bit that I've highlighted in Miller's?
Sounds good. So small myelinated axons, that's A gamma motor and A delta sensory fibers, are the most susceptible to impulse suppression. Next in order of block are the large myelinated A alpha and A beta fibers, and the least susceptible are the small non-myelinated C fibers. Oh, God. In fact, in this last group, impulses in the slowest conducting population, conduction velocity 0.5 to 0.8 meters per second, are the most resistant to local anesthetic.
Okay. So just be aware of that. Okay. And I suspect that it has to do with how, the experiments are done in terms of, I guess, measuring action potentials and the degree of suppression of the relative action potentials or the relative suppressions versus perhaps maybe, the actual nerve conduction as a whole. I'm not sure, but I think that perhaps maybe it's to do with the way that experiments are designed, because how can you get such different results? You've got one textbook saying completely something totally different, and you've got Miller's saying this. In fact, Miller's is the only one that says this, actually, because if you actually read on most other textbooks, like all the pharmacology textbooks, so Rangel and Ritter, Goodman and Gilman, they are very consistent with Hemmings and Hugh.
So I'm a bit confused. I've got to say, when I first saw the table, I thought that was a typo. I thought it was just a editing error. But no, this is not an editing error. They're actually saying that this is,
yes,
I believe. And I mean, yes, that makes me really curious. I mean, Miller's it's the Bible of anesthesia, right? It's
we've proved the Bible wrong before, so right. It has been done before. But let's not get into that, okay? Because
okay.
Could get in trouble.
Enemies. Okay, got it. I mean, that's it. I mean, to summarize, you've essentially covered the physical chemical properties of local anesthetics, framed it in Fick's law. You've really talked about a few things like pKa and lipid solubility and their interactions, the fact that they're not isolated things, that they, lipid solubility interplays with protein binding and potency, therefore volume. Things like, pKa and how you can check the ionized fraction. And that's the one that passes through the membrane, therefore the most important part of it. The fact that molecular weight isn't as relevant in these medications, and the other effects are far greater. The surface area, the 3 nodes of Ranvier, the thickness, which really is the distance to the nerve, and then a couple of characteristics of the nerves as well. So really
I think it's very well summarized. And with the characteristics of the nerves, you can also add, if this question was not just about major peripheral nerves, doing a block intrathecally versus regionally, because intrathecally you've got none of that myelin sheath. You've got direct access to the nerves, which is why you use much smaller volumes and why the onset is a lot quicker as well.
Fantastic.
Yeah. And I guess, look, there's one other population you might want to add in, and that's going to be pregnancy. So, there is that thought that in pregnant patients that they've got a faster onset of local anesthetics. And there's a couple of theories behind that. So one theory is that, so specifically when you're doing epidurals, it's about the engorgement of the epidural veins and that there is less space. And when there's less space, it means that your concentration of the drug within that space rises. So that makes sense. When you're sort of doing things peripherally, the thought is that they've got less alpha-1 acid-glycoprotein, which is the primary binding site for local anesthetics. And so because of that, they've got decreased protein binding, which means they've got more free drug available. And thirdly, could be the effect of progesterone as well, making them a lot more susceptible to local anesthetics. And that's just the effect of, a hormonal effect on the nerves. Okay.
Yeah,
and I think, if you can add that in somewhere, I would frame it with, as you said before, with Fick's law of diffusion, and try to fit those ideas into each one of those. So even, with the idea of, the different nerve characteristics, I'm sure you could put that in with the idea of surface area and also thickness as well. And that's probably where I would add that in. The really challenging bit about this answer is that as you understand, and hopefully after this, this session here, you understand the interplay between lipid solubility and protein binding, and lipid solubility and potency, how are you going to fit that into that construct of Fick's law of diffusion? Because remember that Fick's law of diffusion is proportional to your concentration gradient. And then it's also proportional to your solubility divided by the square root of your molecular weight, and then multiply it by the surface area divided by thickness. And it's that idea of that solubility is just not the only factor here when we talk about local anesthetic. And that's a really key point to come across in your answer, because if you can get that across, it will be obvious to the examiner you understand the really important nuances and concepts related to onset of local anesthetics.
Yeah, nice one. Hey, so at this point, Stan, should we get people to write questions in the chat and I'll read them out to you if people have any questions?
Yeah, absolutely.
Okay, team, yeah, any questions which I can grill Stan with?
Hopefully I've gone through everything. I mean, we can go through, or do you want to quickly go through?
Here's one.
We can also go through, review Stuart Watson's answers as well. I quite like doing that.
Hey, so here's a question. I was wondering what the effect of myelination was on the speed of local anesthetic onset. Yeah, great question.
So does the size diameter of the nerve equal smaller, faster, take priority over myelination? I think that has to do with, that table there, that susceptibility to local anesthetics. Obviously with myelination, you've got the nodes of Ranvier. So you don't actually need to cover the whole node. I mean, the whole nerve. You just need to cover those 3 nodes. And so that decreases the amount that you actually need to cover. But then the other thing that also needs to be taken into account is that the size of the nerves. So the size of these myelin nerves. And what I mean by that is that when you think about it in terms of the larger the nerve and the larger of the myelin sheath, so the A alpha nerves, they're going to be a lot slower. I think the classic example that I would give is that when you look at C unmyelinated nerves and B myelinated nerves, so the B myelinated nerves comes from preganglionic autonomic nervous system, so sympathetics, and then your postganglionics are the unmyelinated C. The B tend to be a lot more susceptible to local anesthetics. This is from Hemmings and Hughes compared to the unmyelinated C. So for like, myelinated would be faster. Does that answer that question?
Yeah, thanks, Dan. Now, the next question is, why is it that the M gate needs to be opened? That is the active or inactive state.
Good question. So this has to do with how local anesthetics work. And the key thing is that you need to know where the binding site is for local anesthetics. If you understand or know where the binding site is, you know why the gate needs to be open. In other words, the binding site is actually inside the pore. And to get access to the pore, there's 2 ways to get access to the pore. One of the most common ways is to have the channel open. To have the channel open, then your local anesthetic can diffuse across, and it's the aromatic side of the local anesthetic that binds to the binding site, and then it's the it's the other site that sticks out and blocks the channel, and also stabilize. And then the whole local anesthetic then just stabilizes in its inactive state. Now, the other way that you can actually get access to the binding site is through diffusion through the lipid membrane. That's a lot slower. But then I think they'll give you some examples of why there are some types of local anesthetics where it doesn't actually require the M gate to be opened for local anesthetics to work. But certainly, if you have the M gate open, it's going to be quicker, okay, because of where that binding site is.
Excellent. Next question. When you discuss thickness, you relate to distance local anesthetic needs to travel in respect of the size, that is diameter, axon to stroma ratio. Do you put this under the same sort of heading or under the nerves sensitivity to local anesthetics?
I would put it under thickness, but certainly you can. I think that it's more than reasonable to put this under nerve sensitivity. I guess nerve sensitivity. Okay, the only reason why I'll put this on the thickness is so that I could frame it within the Fick's law of sort of diffusion in terms of the formula related to it. But yes, I think that, that's just a personal preference. I think I've seen multiple variations of how you could answer this question, and you could have another column or another subsection after the Fick's law that you could add as other considerations, one being the sensitivities to local anesthetic, which then you could put that in. I think that's more than reasonable. Like, you don't have to follow what I prescribe. I think it's really nice to have that bit of creativity in terms of what makes sense to you. And I think that, if we were to read someone else's answers, Fick's law of diffusion would probably be the way that would frame most of their answers. But then you would also see, I think, other considerations that they would describe, which probably, they didn't feel comfortable in fitting into those ideas there.
Next question. Is there actually evidence to support the idea of active nerves, that is moving the limb to increase the nerve channel opening, speeding the onset by allowing faster access to the interior of the cell?
So you're talking about, this is frequency dependent block. And yes, so there is that idea about, if the more channels you activate, then the more you have them open rather than in the resting state, and then the more you allow them to sort of diffuse across. So the question is whether there's evidence. I don't know whether there's evidence, but I think that there's that, I must admit, I haven't sort of looked into the research. I don't know whether if you could do a quick lit search now, La, as I'm talking.
Yeah, absolutely. Doing it now.
But there is that idea of frequency dependent blockade, and the idea that as you block those channels and as they cycle across from the resting active to inactive state, the time it takes to cycle, to do that one whole cycle, is actually a lot slower than it takes for local anesthetics to diffuse out of that channel. And what that means is that as you continually allow to open up more channels through this, moving the limb or activating the limb, then the more channels get blocked.
I've just literally, it's the first Google kind of search I've done. Frequency dependent block in humans by Candido, and this was in Anesthesia Analgesia. It was letters to the editor. So in response, we concur with Stevens that as our study demonstrated, a frequency-dependent action of local anesthetics is unlikely to be a mechanism at work in stimulation-induced, i.e. muscular exercise, reductions in latency of onset of sensory or motor block following peripheral nerve injections in human. Now that's a whole mouthful. So essentially, it's unlikely to be a mechanism at work in stimulation-induced reductions in latency of onset of sensory or motor block following peripheral nerve injections. In fact, frequency-dependent block, that is use-dependent or phasic block, is likely to be limited clinically in humans to cardiac tissue exposed to critical concentrations of tertiary local anesthetics. So experimentally, sodium conductance decreases with repetitive neural stimulation. In vitro studies in mammalian peripheral nerves and in cardiac tissue demonstrated that the intensity of depth of impulse blockade increases as the rate of stimulation increased. And then, they're getting into some pretty detailed stuff here. Yeah.
Great.
Well, but if anyone finds anything else out, that'd be really, really useful to let us know. So the next one is, why does increased lipid solubility translate into increased protein binding?
Now that's a chemistry question. So I think that the concept, that everyone can agree on is that when you increase lipid solubility, it's going to be associated with increased protein binding. I think we can all sort of agree on that. And I think that it has to do with how the bonds sort of occur between the drug and the protein. But in terms of the mechanism, I'm actually not sure. I think it's a great question, but I think what needs to be appreciated is just that idea that increased lipid solubility is associated with increased protein binding. In fact, if anyone has an answer to that, yeah, please share it with us. So if you want to put it into this chat here, or even, send us an email or put it down in the comments below, that'd be great.
Beautiful. Hey, Stan, should we close on that?
I think we've done well. This has been, a great hour. And look, I think that hopefully all you guys, sort of leave this session today with that understanding that, there's a lot of nuance in terms of the onset of local anesthetic. And what the key message I want to sort of have you sort of come across is that idea of lipid solubility, that idea of how lipid solubility is associated with protein binding and how lipid solubility is also associated with potency as well. And it doesn't present the full story of the onset of local anesthetics. And also the idea of how and why pKa is more important.
Yeah.
And I think if you can take that out of this session, I reckon you're more than 50% away there to, answering this question really, really well, because I think that's what actually confuses a lot of trainees.
Stan, thanks so much. That was fantastic. I mean, so we went through the speed of onset of blockade of local anesthetics and a major peripheral nerve. Again, I love the detail you go into this, but I think I learned quite a few things as well, which was really great. So yeah, thanks everyone for listening and watching to this combined episode of Adrenaline Memories and Anesthesia Coffee Break. And yeah, we'll see you next time. Please share with anyone who might be interested. And yep, all the best for your study.
Great. Do you guys enjoy that? Hopefully that makes sense to you. I know that, I think if you get that point across, I think you'll be, as I said, you'll be more than halfway there already. I think that's a really key point that I think confuses a lot of trainees.
I'm just going to ask a question here in the chat quickly before everyone signs off. Hey, Tom, I just asked you a quick question there in the chat.
Who? Me? No?
Okay. Beautiful.
Yeah, I don't mind whatever's easiest. I'm not fast.
Yeah, too easy. Thanks, Tom. Cheers.
All right.
Okay.
Have a great Saturday, guys. Shoot me off an email if you have any sort of questions. It's are you guys going to aim all for March, or who was sitting in August here? Everyone's for March. Excellent, good stuff. Are you guys all going to the Melbourne course in November? Yeah, excellent. I'll see you guys there. Hopefully you come down in person, because I'll be there in person, and we'll have a day where we're just gonna do respiratory physiology.
Beautiful. I'll see you guys when you're all really tired in the very last session. So,
it's the best session. It's the categorization drills.
We'll see.
Yeah.
Thanks, guys. All
Good work, guys. I'll see you guys next week. Actually, you stay on the line, La, because I want to have a chat to you quickly about next week.
Yeah, easy.
All right. Thanks, guys.
Yes.
Hey, next week.
I've got a big day on Saturday next week.
Oh, do you? Okay, what's happening next Saturday?
And I've got I'm running a ABCs of Anesthesia course next Saturday morning, 8:30 to maybe 11 or so.
Yeah,
something like that. So I could do after that.
Yeah. Oh, well, we need to do a session on mums. So the mums want to come together and do that, session on challenges of being a mum and getting through the exam, because it's a continuation of what we did previously, where a lot of mums failed, and now we've had a lot of mums succeed.
Amazing. Do you want to do that Sunday?
Sunday? Let me look at diary. Sunday is better for you, yeah?
Oh, I mean, either one. I'm always kind of keeping this Saturday morning space for me, allow me to be a bit hungover and still do a session. Like,
Yeah, you're looking all right though, which is good.
oh, thanks, Dan.
Sunday, oh, I don't know, Sunday evening?
Definitely not evening. I'm just buggered by the evening.
Are you? All right. We might need to do it 12. Sunday morning on the 13th.
Why do I feel like I've got something there? Yeah, Sunday morning on the 13th. Yeah, could probably
All
do
right.
that.
I'll send an email. I'll confirm it with you. I'll send an email around and ask.
Yeah.
And then
Beautiful,
I'll confirm it. Yeah, 13th.
Excellent.
Either Sunday, yeah, 13th. Let me just see what else is there. Or 13th or 12th. 12th is okay with you as well, isn't it? 12th or 13th. Oh no, 12th I can't. 12th I've got Luca coming on at midday to do a session. So
cool. Yep, 13th. Let's yeah, let me know and I'll lock out the diary for that.
Yep.
Good way, man. That was such a great session. Like,
you enjoyed that?
I learned so much as well. So that's great.
Like I think that. So sorry, I'm so late because like I was looking at Miller's. I was going, what the fuck is he going? What the hell is he going on about here?
That's not a trivial difference. It almost makes me think, are we really sure about it? Like that's how.
Well, that's why that's why it came out so late because I was going, oh shit, this is Miller's. Yeah. Like I can't go on a a podcast like this and just back Miller's out without actually doing due diligence.
Yeah, that's right. Oh, you can because no one cares. I mean, actually, historically, we'll be judged for whatever we say now. So you're right. Thank you for checking that out. Hey, look at what Fred Huller sent me.
About bloody time.
Yeah, they sent me a frame. I think that's hilarious. I mean, I really appreciate that they've sent me a $50 frame of something like that. That is actually that is lovely. Yeah, that's nice. That's nice.
Well, considering you've donated like 100K or more, is that right?
Yeah, 100 and something K. Yeah,
mate,
better do it.
You know what? Like you should do it for. I know you don't like ANZCA, but I think that it's more powerful. I reckon it's more powerful to do it with ANZCA. Like, I'm, doing with ANZCA now. It's just like amazing.
What do you mean? They interact with you and stuff, or?
Well, the thing is, no, not to say interact with stuff, but I think that you definitely increase your profile, and you'll be only one of. Well, I'm the fifth one.
Yeah.
3 people are dead.
Yeah.
One's retired.
Yeah.
And it's me. And so you'll be one of 2 living practicing anesthetists.
Yeah.
Who are the major donors of ANZCA.
Yeah, look, that is actually pretty tempting. Like I think that's the space that I have difficulty is getting. We're working outside of ANZCA because we think ANZCA is slow and doesn't necessarily. We should probably stop recording.
It's all right. It's not going to come on. No.
No. Yeah.